Hello and welcome to A Blind Date with Knowledge, the podcast shining a spotlight on research in the Northeast. My name is Stephen Liggett and I'm joined today by Laura Brady.
Hi, Stephen.
Hi, Laura. We've both been super excited to record this episode. We're sat in the National Horizons Centre, which is part of Teesside University, and we've just had an amazing discussion with Professor John Young.
What an excellent discussion that just was. We spoke firstly about early detection diagnostics for chronic conditions, particularly in urology, and then moving on to wearable devices and education. In fact, such a great conversation that we'll have two parts of this episode.
Yeah, so this podcast is going to be a special two-parter. So should we just get into it, Laura?
Yes, let's go. Part 2.
Here we go. This is potentially a good segue into maybe your wearable device. Because if you take the dipstick test as times that we have done the test in the lab with a research nurse there, that's very subjective as well on how you look at the colour, how you read it is really subjective. So 2 or 3 of the conversations that we've had, especially with the MedConnect North discussion, it was how we start to use some kind of devices to be tracking these changes continuously. I suppose the question is, do you or any of your team have device projects in the pipeline, John?
Yeah, we've got quite a few, either that I'm leading or involved in, because I think this using AI and using sort of advances in technology that come out in the last 10, 15 years, that's probably the answer to this proactive approach to detecting early. I think one of the reasons for doing that is that if you have a single test that uses a biochemical reaction like the dipstick test that we just talked about, that it's almost impossible to get a test that works for everybody because the levels of the chemicals you're trying to detect vary, and they vary because of individual factors. And therefore, you might get a test that works well for some people that doesn't work well for others. And that's why sensitivities and specificities, sensitivity being how kind of early we can detect something, really, and specificity about distinguishing it from something that looks like it. Those numbers are often quite poor for tests, and it's usually a trade-off where it's one or the other, right? So the COVID test had high specificity, 99%, but its sensitivity was at best about 73%, I think. And it was a really wide range. And those were numbers from ideal conditions in the laboratory, not, performed by the 3 of us. So, well, I'm sure with your pathology backgrounds, you'd be like smashing it, right? But I'd be, terrible. I'd be weird.
Just a quick tickle. I used to just... Anyway,
that's
a different story, maybe.
Yeah. So difficult to get a test which works for everybody. And that's why, one of the approaches is to have other methods that give, a range of different outcomes that then an app or a little onboard processor can then interpolate, things like that. So we're developing some electrochemical devices, so measuring the concentrations of chemicals rather than looking for a color change with a very specific window for that color change, or, using other approaches as well. So we've got a number at different stages. And I'm happy to give you an overview to the best I can without breaking any contracts. But essentially, in broad terms, I think this is where the future is. So, there's a lot of interest in having innovation. Whenever you speak to patients, carers, or clinicians, they all want new tools. And, something that we, I suppose, might go on to is that that's not always universal. So although we can innovate and we can make these tools, it's not as simple as just making them and then they're available, they'll be used and everything's wonderful. Actually, there's big infrastructure that's required to make something like that successful.
Absolutely. It's a long road of testing and of trials, but I think it is definitely the future. A lot of people in these spheres are driven by patient benefit, wanting to help people like that. And I think the pledge to provide the best possible care that you can involves staying at the precipice of new innovation or new technologies. Like, unless we're sort of incorporating them into modern treatment, medicine, management, then, you know, we'll get left behind. The sort of colour comparisons is a bit outdated, and it's really, really good to hear like all of the work that's going on to develop them. Yeah. So it also is in relation to like the education, how people are then going to use those, because, you know, there's a lot of people who have reservations about new technologies and AI. So what would your comment to those be about sort of how do we accept those into our communities of not just sort of practitioners, but patients and carers and like the care home workers and things like that?
So I think for people wanting to develop those devices, I would really encourage them to speak to stakeholders and to involve them through the entire process. So not just a perfunctory kind of quick chat, but, you know, actually speaking to them and understanding what they need from a device and how they want to be able to use it. So that's what we do in developing our gadgets and gizmos. So we worked with a company in the States called Leo Medical, and they'd produced this patch that sits on the forearm, and it measures properties of the blood, particularly measuring a property of the ECG, the T wave, which properties of which directly relate to the amount of potassium in the blood. So they had this amazing technology, and it has so many different purposes. So the first use is in dialysis patients, and it's important for those patients to be able to manage their blood potassium. Too high or too low can have really catastrophic effects for those individuals. They can become seriously poorly and they can die of a cardiac arrest. So it's important to be able to manage their potassium. And the way that that's done currently is they go into a hospital, they have a blood draw with the caveats that Stephen was talking about, you know, hemolysis and 20% of blood draws, something like that. Yeah. Maybe 15 at the moment, but traditionally about 20%. Wow. And then they get a single value. So it doesn't tell you what your blood potassium is right now. It doesn't tell you what it's going to be. It tells you what it was when you had that blood draw, and that's it. And so by having a wearable that allows you to see what your blood potassium is at any given time, allows you as a patient to be able to manage that. So anyway, we did a big piece of work with patients, with carers, and with healthcare practitioners to say, well, you know, this is the device. You know, what do you think? Would you use it? What are the barriers to you using it? And it was really interesting. So I think we all probably think that when there's a new innovation, that innovation in itself, if it's designed well, somebody will see it, they'll recognize what it's to be used for, they'll pick it up, they'll start using it, it's going to change their lives, right? So we, you know, grew up on Tomorrow's World with flying cars and all this sort of stuff. You know, the idea that you would pick up a flying car from the dealership and just fly off in it, right?
Just fly off away.
You know, but obviously, you know, it's a silly metaphor, but you clearly wouldn't. You'd need training in how to do it. And the same's true with a new device, you know, and that's true for not just a patient, but for a carer and family members, you know, that might want to support the individual, but also for the practitioner. And so, you know, it's not kind of glib to say that when we had these conversations, it sort of opened a massive can of worms, because practitioners want something that provides the safety of those patients that are using the device. So they want to be entirely convinced that the numbers that the device produces are accurate. So they don't want to be making clinical decisions based on something that they don't trust. So trust is a huge part of all of this. They also want to be able to access that information in a way that suits them because of their huge competing demands on their time. So some clinicians might want a dashboard, and when they've got a kind of clinic on a Monday, they want to see the different patients that are wearing this device and be able to review the numbers, you know, what's their number at the moment, and then let's have a quick look at the trend over the last 7 days, and let's see if it's departed, if it's gone up, if it's gone down, the kind of the window of healthy levels. And then if it has, they then might arrange an appointment to see that patient and just talk about how they're managing it. So, you know, it went up on Tuesday. What happened on Tuesday? Oh, you had a takeaway. Right, well, maybe stay away from the takeaways because there's loads of potassium. Or if you're having a takeaway, maybe stay away from that dish and have this dish or something. And then for patients and carers, it was really interesting. So, you know, a patient with a long-term condition, it's a huge burden to them in their lives. They welcome the idea of having something that helps, but it can't be burdensome. So even if it's a step backwards to have 2 steps forwards, that step backwards is too much for them. right?
It's to be integrated into...
and really super simple. So, for example, there could be an interface that, like a smartwatch, has got numbers and graphs and all that sort of stuff. But, for most patients with long-term conditions, they might be older, irrespective, they might be a technophobe. There might be limitations on them using technology such as infrastructure, Wi-Fi, 30 minutes away from here, all the dales, poor phone reception, let alone Wi-Fi and things like this. Really challenging for them to kind of have a piece of tech that talks to a hub, where that hub talks to the clinician. That's it. And so, they probably, at best, they articulated they want like a traffic light system. It's green, everything's fine. It's amber, something's not fine. I click on the watch and it tells me what I need to do. It's red. Okay, I really need to do something about this. It's a bit of an emergency now. What's the urgent action that I need to take? And likewise, a clinician might need all of that. Now, everything I've described, and I've tried to summarize it, requires quite a lot of an infrastructure. And so, this new tech is really important, but all that infrastructure is required. And I hope I answered your question, Laura. I probably answered about 10 questions you didn't have as well.
That's a great answer. I think it's really intriguing to have that image in my head now of the dashboard, sort of where clinicians can see all their patients with devices on. I think we have we're moving from an age of that sort of snapshot data to like continuous data. And as you're saying with the technology, it's not easily accepted into everybody's lives, but for a lot of people, they've already accepted it into their lives for like entertainment purposes or just sort of general sort of cardio record on
maybe
like
for younger
Fitbits and health care. So I think it's a matter of time. But there is the gap in sort of the younger generations and older generations, and how we bridge that gap is interesting.
There was one thing while you were talking, sorry. So, we found from, I think it was the beginning of COVID, maybe just a little bit before, when some GPs started to move to video appointments. And I think the three of us would see the advantages to that. And it's easy to see the advantages, but you might recall that some newspapers published a number of articles about the negatives of that. So whether or not they were real negatives from patients, or it was a bit more of a sort of a political thing to try to go back to the way things were. I'm not sure, but I know that, many people benefit from having an appointment full stop, but there's something better about a face-to-face appointment than having, say, a video call. And I think one of the barriers that we came across when we talked to patients is they didn't want to not have in-person appointments with their consultant. So they didn't want their care to be handed over to a device and an app or a watch. That's really important to them. So the idea is that any device that we develop or we're involved in developing and that then gets integrated is done so in addition to standard care, not to replace it. I think there will be a time where certain aspects do get replaced, but only when there's a huge body of evidence that it's safe to do so and that everybody participating consents to that. And I don't think anything would happen. And we didn't talk about data either, about, accessing data and things like this. So it's a
different conversation, that one.
But it's all part of that. And so I only partly answered your question. I think there's a huge amount of potential issues to address. And, when I've taught this, because I do a little bit of teaching still at the university, and I meet with district nurses, I teach district nurses. They go out, obviously, and they see patients with long-term conditions. And a good kind of example to get people thinking about the complexity of this is to think about diabetes type, particularly, well, I don't think it matters, type 1 or type 2 diabetes mellitus, and how a blood glucose monitor is an innovation. And it's the same type of thing that we're talking about here. But for a blood glucose monitor to be effective, it isn't just a case of, buying one from Amazon and giving it to a person, right? So they have to regularly test. And when they get the numbers, they need to know what the numbers mean. Then they need to change their behavior if the numbers are high or if the numbers are low. To change their behavior, they need access to the right foods. They might need to change the timing and the volumes of food they eat. And they might need to do other things like quit smoking, do more exercise.
It's like a mindset comes into that as well, because even if they're sort of at a position where they understand the numbers and that's received well, the mindset to actually to do the behavior change is a different step up in itself.
And there are other barriers. So it's all very well saying to somebody, you need to do more exercise. But, if you put on the gym kit and it doesn't fit, or you put on the gym kit and you feel, like not that you just don't feel body confident or something, you might not then want to do that exercise. Or if you go to the swimming pool and it's just full of kids splashing everywhere and dive bombing in and things like this, and so you can't even swim your lengths. Or it's not safe to run around where you live, or you don't feel safe, or something like this. So many barriers. And again, it's a bit of a minefield. So it's brilliant to talk about innovations, but we have to do so within this, think about how inventors or teams developing these things can also influence that wider infrastructure. We can't do it just in isolation. And I'm always kind of keen to emphasize that just producing a dipstick or a wearable or something like this isn't it. It's the start of it. There's so much more to do.
To me, it's absolutely fascinating that pretty much everyone that we have spoken to on this podcast talks about the complexities of just treating a single patient. So you need access to education, you need access to gyms, you need this early intervention from, say, your local health authority. You need access to GPs, to primary and secondary care. And all of that is a challenge. So perhaps before we go, because you've been so generous with your time, John,
no, not at all.
So there's a regional pathology research network that was developed by the National Institute of Health and Care Research, and we were very lucky to have John present a new doctoral training program. And I don't want to take away your thunder, because you will describe it in much better terms than I can, John. But you talk about using this program to it has to be tailored towards a challenge or a barrier to improving the patient experience at trusts. And you spoke about at the very start about you came to Teesside because it does translational research really well. And I hope this training program will actually start to utilise all of the expertise in the Northeast, because you've developed it with universities, with industry and the local trusts and things. So could you maybe spend a couple of minutes discussing the training program you've developed, what it is, and how people can maybe find out a little bit more about how they then try to apply to come onto this great, fantastic opportunity that you've developed, John?
Yeah, with pleasure. Thank you. So the scheme came about because I think we want to produce impact from our research. And traditional research takes a long time to do that. And we talked about some of the reasons why that might be the case. And in the National Horizon Centre, where we're based, there are currently probably about 20 PhD students, some above our heads, some in the various labs, all kind of beavering away. To translate their discoveries into new medicines might take 15 to 20 years, new diagnostics, 5 to 10 years, all with millions of pounds of funding and a fair wind, without other people competing and doing the same thing faster or better or whatever. So there'll be lots of barriers to any really exciting project, even making it out to benefiting the lives of patients, carers and practitioners. And that's frustrating to me, particularly when I think, some of the work that can be done in academia might not be as impact focused as it could be. It doesn't necessarily begin its life by hearing from stakeholders about what their needs are. So when we do that, when we have conversations with patients, carers and practitioners, the same things come up again about that need for innovation. And when you marry to that the need to innovate within the NHS. So the NHS is just the best thing that's ever come out of this country.
I agree.
It's just an amazing thing, and we should hold it true to our hearts. We should protect it at all costs. But the reality is it's been underfunded for at least 10 years. And, it's at the same time as it being underfunded, we've got an aging population. We've got greater number of people with long-term conditions than before. And it creates a huge challenge, particularly in the Northeast, where people live shorter lives than elsewhere, and a larger proportion of those shorter lives are spent in ill health, about 20% more of their time. So there's a huge demand regionally as well as nationally. And other people much brighter than I am have done analyses as to what's required. So if you want to address this effectively, it costs tens of billions of pounds, and there's not the money for that at the moment. And so, for example, the King's Fund, I think it was 2022, really good report, they conclude that what we need to do is to build capacity within the NHS. We need to take people working within the NHS, and we need to provide them with the skills and the support they need to essentially innovate. Yes, people are in exactly the right setting to change what's required, right, with some support. We won't be able to solve everything, but actually we'll be able to solve quite a bit by doing that. And I personally had a really positive experience of doing that. So I've already gone over 2 minutes.
No, this is great. So,
finish now. Cut off.
So I'd had a PhD student when I was in Portsmouth. His background was in, so he'd been a computer scientist, but he was working as a healthcare scientist, biomedical scientist, analysing blood samples to measure products of kidney metabolism, which can be used to indicate a condition called acute kidney injury. There are 3 different stages of acute kidney injury. Each is associated with, quite bad symptoms and further morbidity, further illness. But as it progresses, mortality becomes an increasing risk. And stage 3 acute kidney injury is quite serious. Well, they're all quite serious, but especially so quite high mortality rates. And it used to be the case that you could have a particular threshold of this chemical, and you look at that, whether the chemical goes above a certain point. If it does, it's a flag for acute kidney injury. But there's loads of exceptions to that rule, including, some individuals for different reasons and pregnant women who you just can't have the same threshold. And so he thought, well, could we not just have an algorithm that looks at different kind of components? So he made a little computer program. When he and colleagues would measure this blood chemical, it would then look at the rate of change of this chemical and looking for like an upshift. Yeah. And when there was that upshift, he developed an algorithm that flagged to clinicians, to clinical teams, that there might be an issue and that it should be investigated further, looking at other chemistry, looking at physical symptoms. And doing that changed how acute kidney injury was diagnosed in first his hospital, then within the region, with 4 hospitals in the region. So he analysed all the data and others analysed the data, and it was showing that this simple intervention, massively impactful. And I had a second student, I won't give you another anecdote, who had another approach. Now, both of those individuals were based within the NHS, and they worked within the NHS, and they worked part-time. They were given a day a week, and they looked at what they were doing, often taking the same patient samples, maybe analysing a different component, with ethical approval to do so, measuring some other chemicals, taking the data and developing algorithms, using AI to look for patterns, all this sort of, simple innovations that we can do if we have the time and the support to do so.
Absolutely.
And so I think that's a real sweet spot for kind of developing much needed innovations.
Yeah.
So I went to a charity to ask for funding. I'd been working with Health Education England. And at the time that we're talking, contracts have not been signed. So we haven't got the go ahead yet. Yeah. But both parties have committed to this verbally and in an email. So fingers crossed. Now we've got on the podcast as well.
This is no pressure. The third one.
It has to happen now. So and then so in the final part of your question is like, how do people apply and things like this? So, or how do they find out more? So when we got all the contracts in place, it will go live. One of the people involved is a chap called Professor Stephen Cobb. He's at Durham. So he's very experienced, like myself, at managing PhD students and doctoral training programs. I wanted to make sure that there wasn't just a single point of failure. So he and I would do this together. Doing that allows us to call upon the infrastructure at Durham as well as the infrastructure at Teesside University. And it allows us to have quite a wide, probably national offering actually, but ideally regional, because I think that's where the need is. And so once we get the funding confirmed, we'll advertise that and we'll have that call. And then we use the same model. Just very briefly, we went to another funder. So I was aware that there's a big issue in this region to do with dental issues. Mm-hmm. So there's certain kind of ethnic groups, so particularly kind of traveller, Roma, Gypsy ethnicities, and then also migrant workers, people working at some of the large centres that we know about that attract sort of migrant workers. These individuals are known to particularly suffer quite badly with long-term conditions. Mm-hmm. And one of the most acute things, the things that we see earliest, are problems with dental illness. And we know that links to things like Alzheimer's and other conditions, but it should be seen as a red flag that there's a problem regionally with sort of spotting and treating illness, because it's just one of the first things that transpires. Mm. And so myself and a colleague approached another charity to say, we think there's a potential model to treat this better, or to address this better, by involving practitioners. And so they've agreed to fund 3 more studentships as well. Nice. So again, we have to go through a formal process of applying for that funding, and it could all fail, everything could. But I think that this is a really important model, and it's something that I'm willing to, to put a lot of effort in promoting.
For me personally, it kind of ticks all of the boxes that we've discussed, is that you're using expertise from the staff at the front line, like Laura's discussed, and then you're giving them the help and support, and you're starting to think of how you focus this help and support and expertise on a particular problem, and there's fingers crossed it does happen, and we'd love to come back and maybe chat to you again, or some of the PhD students.
That would be great.
Once the training program's up.
Yeah, it would be great to see how you're getting on further down the line and see what the impact is.
Yeah, I'd love that. I think speaking to them would be much more interesting than speaking to them, because I think it'd be interesting to know what motivated them. Because when you speak to people in the NHS, and you're both from that background, these are not people just doing ordinary jobs. Everybody that works within the NHS is so passionate about what the NHS is and what it aims and delivers to achieve. And so this isn't just a qualification for qualification's sake.
No, it's really...
This is people wanting to get a skill set so that they can innovate and that they can support others to do the same. People that have got in contact with me about wanting to do this scheme articulate this real passion for trying to develop entirely new ways of working, to build capacity to address this bottleneck within their system. And that's so compelling.
Totally. And I think staff will just be appreciative of the fact that their skills are getting utilised. There's a lot of now training schemes that I've been on various things myself, and then you come back and there's a bit of a void of how you then start to implement the skills and the knowledge you've developed. This training program brings it all together, and so you're kind of developing your skills and using the new skills in the same program. And because there is a bit of a void between how we start to use the people that have these new exciting skills and the projects that they can work on and things. But for me, it's been a fantastic conversation. I mean,
it's very kind.
The rest of the guests maybe close your ears, but this has been my favourite.
Oh, wow.
Favourite one of the...
That's on the other side of the book, that is. The other side of the book.
No, so...
Wow. Laura didn't say it was her favourite one.
No, Laura didn't,
by the way.
She's going to now, I think.
Oh, I was going to say... No.
Wow.
No. What I was going to say is I think...
So awkward, isn't it?
No. It's interesting talking about how it integrates everything in the program, because when you're talking about the NHS being overburdened, this is one of the ways where becoming more qualified, and it doesn't become more of a challenge. It actually helps to tackle that burden when every individual takes that responsibility. And I think we could sit and talk here all day and continue to talk, but be good to come back and review again. Maybe that one will be my favourite. and I'll leave it at that.
Right.
We'll cut this out, Jan.
Yeah, no, definitely don't. Just do that bit and then
that's it. We'll stop on. It's been the best one.
A minute of awkwardness.
Yeah.
Thanks so much for your time, both of you.
Thank you for your time, Professor, and thanks very much for sitting down and speaking to us today.
It's a pleasure. It's a pleasure. It's lovely to talk about the work that we do, and we often don't get the chance to do that. We focus on minor details. There's a slight problem we need to solve, or this becomes. Academia is about, more and more about less and less.
Yeah. The more you know, the more you find out that you don't know.
That you don't, then it's just
that's on the t-shirts.
So that was part 2 of the Professor John Young podcast episode. If you have any comments or questions or any feedback, then please do get in touch. And John mentioned maybe coming back to catch up on some of the PhD applicants from his training program. So that'd be really good, Laura, do you think?
It'll be great to check up on the progress and see the sort of impact that has.
Absolutely.
Moving forward. Yeah, and stay tuned for more information, which we'll be sharing once it's available.
Yeah, absolutely. And the best of luck to anyone who applies for the training program. Hopefully, this discussion has kind of highlighted the fantastic opportunity that could arise for someone.
Thanks for listening.
Thanks for listening.
We look forward to seeing you.
We'll be seeing you.
Stay tuned for the next episodes where we discuss our continuous themes of collaboration, education, and clinical research.
This might just be the last one, I think.
We're done.
Yeah, I think we're done. No, I'm joking.